Hello everyone, I'm Dr. Nagendhar, Chief Pediatric Surgeon from King's Cuddles Hospitals, Hyderabad. I cover Secunderabad, Kondapur, and Gachbowli King's Cuddles Hospitals. As pediatric surgeons, we often see many parents coming to us telling that my child has got this problem, and that is when we interact with them and then we tell them, yes, this is the problem, and we give a solution to the problem and with utmost care and concern. But sometimes it happens that a school going child, he goes to school, but he doesn't child doesn't know, and parents doesn't know. Of course, teachers actually in this busy schedule, they may not be able to detect. So today I thought actually we'll discuss about the school going children. What are the commonly missed problems which alert mother should be careful about? So I often tell actually mother is the first doctor from the home. So as all of us know, actually our mother is the first doctor. She'll be diagnosing everything. She'll be giving the primary basic care, and then only she'll go to the doctor. So she is the first doctor of the family. So with this introduction, actually, I want to introduce my team. Actually, we are a team of 4 pediatric surgeons. We'll be covering full-time Tim Cuddles Pediatric Surgical Department in Hyderabad. Next. So in the last school health camp that we did, we detected some health problems. Something like starting from small tongue tie problems to a bedwetting problem to a hypospadias or some other concerns. So there are so many number of problems which we have detected, and all these problems actually needs to be addressed and needs pediatric surgical care. And by giving timely intervention, actually we are going to manage these problems very successfully. Next. So in the concerns, actually, there are some concepts where what surgery should be done at what time. So, for example, my child has got hernia. So hernia is a semi-emergency operation. So it needs to be operated as early as possible because it can go into irreducibility. So, for example, same thing, hydrocele. Usually in a child, if it is detected, actually we wait for 1 or 2 years. If it is regressing, if it is not regressing, we'll go for an operation. And if it is a case of undescended testes, sometimes testes won't come down. If that is the case, what we do is we wait for 6 months of age. After 6 months of age, actually we operate. So suppose actually, for example, it is missed in the school going age. Even then, actually we are trying to protect the testis and we bring it down and put it in the normal place for future function. And sometimes the born babies will be born with the joint fingers. That's what we call the syndactyly. So if that is the case, actually we'll operate at 1 year of age. So phimosis is a common problem, but usually till 1 year it is physiological, no need to operate. Only at 1 year of age, actually after 1 year of age, we'll start intervening with it. Doesn't mean that we are going to do an operation. Without operation also we manage. So for a hypospadias, where the urine is coming from bottom surface, these things actually I'll come discuss in the coming slides. So if hypospadias is there, actually we try to do it before the child goes to the school. After the child goes to the school, it will become a social problem for the family, for everyone, and child's self-esteem. That's the reason why we operate before the child goes to the school. And cleft lips and palates, there will be some speech defects also. So these needs to be addressed separately. And nowadays the trend is more towards early reconstructive operations rather than the traditional age-old techniques. So sometimes actually, as per good parents, actually what we should know is which child needs a special eye. So for example, actually I have quoted few of the things. A child who's totally inattentive, a child whose mother is not able to manage at all. So that child might be having some behavioral issues or autistic behavior or some other behavior. So for that, some behavioral therapy is required, and which we do very well in our child development center. And a child who's sleeping too much, he's not attentive, he's not listening to the class. So maybe his thyroid is a problem. Actually, he needs a thyroid evaluation. For that, we have to come to the pediatric endocrinologist who's with us, will take very good care, and then he'll evaluate and then give the correct treatment. And this thyroid treated in time saves a brain. So, for example, actually, a child is the shortest in the class. Is we call it as two standard deviations. If it is below that, if he is like that, that is the case actually where maybe his growth hormone is at a fault. So he again needs a pediatric endocrinologist. He will take care of your growth hormone assessments, and then, if necessary, he'll give the corrective replacement therapy. A poor reader in class. Maybe he's not able to hear, he's not able to see, his eyes needs to be checked up, and maybe he has got some dyslexia, actually, where he's not able to understand the words, like what we have seen in the movie called Tarzan, or something like that. Maybe he needs a neurologist assessment as well. So these things should be detected by the mother or the teacher in the class, because the child doesn't know that he has a problem. So it is our responsibility as good parents to take care of them. So every child is not an adult. So he cannot tell, yes, mama, actually, I have a pain abdomen, I have this problem, that problem, and all. So for that, actually, a good mother is very important, or a good teacher is equally important. So abdominal pain in children, actually, or abdominal distension in a child is a thing which needs to be taken care and addressed totally differently. So, at the same time, it should never be neglected, because sometimes it can be a simple gastroenteritis or simple and indigestion of food, but sometimes it can be lead to something called as a abdominal compartment syndrome, where things will be totally disastrous. So, a child needs to be addressed and tackled totally differently, and mother plays a significant role in this management. So sometimes we'll be in a very having a tough day addiction timing, and emotionally the time itself is very bad, and slowly one learns with experience. And as pediatric surgeons with 20-25 years of experience in pediatric surgery, we know exactly what the child is trying to tell and what he is trying to do. So it is for us to decide, actually, as pediatric surgeon, we know when this child needs attention, when he needs an operation, when he doesn't need an operation. So coming to some common problems, something like tongue tie. It is detected usually at the breastfeeding time or later when the baby starts is not talking well. Sometimes parents or grandparents, actually, when the child is stammering or he is not talking properly, they'll just appreciate. Actually, yeah, very good, you're doing a good job. But unfortunately, maybe he's suffering from what is called as a tongue tie, actually, where the tongue is stuck below, and then he's not able to pronounce some of the letters. So, for example, in our teaching, actually, whatever we did, that ta ta da da na, that full line, it requires the tongue to go and touch the palate. So it has to tongue should go up and touch that, and only then he will be able to pronounce it. Suppose if the tongue is not touching that area, actually it will be falling back, and then it will come as tata dadana. So whenever you ask him to tell tata, he'll tell tata. So that means he has a problem that needs to be corrected, or else in future actually he is a candidate who will be prone for bullying. So he needs a surgery, ideally after 1 year of age, or whenever the child problem is detected. So one other problem actually sometimes actually we notice is torticollis. So maybe actually sometime actually the child will be keeping the neck like this. That is because his neck, the muscle is very taut. It is not allowing the neck to straighten up. So that is when the child will keep like this only. We think that it is a mannerism, but unfortunately it is something to do with the muscles, which is called sternocleidomastoid muscle, which is tight. And if it is treated early, actually in the child, in your early childhood, with physiotherapy only it will be managed. But in a school-going child, actually, the child requires a surgery. And with surgery, actually, everything should be corrected. But in that time, actually, child may be having some vision disturbances. So vision disturbances need to be addressed carefully. So sometime back, I was talking about syndactyly, where the fingers are joined, and baby is born with joint fingers. So till 1 year of age, actually, that both fingers will be at the same level. But after 1 year, actually, slowly the fingers will start becoming different. So this is the time when actually child needs the fingers to be released. So this releasing is a special technique where we'll be using so many zigzag Z plastics, and then we'll be doing the corrective surgery, and that will give a almost near normal life to the child. So some often, actually, all of us we never bother to take care for belly button. So it is never dry, it is never wet. always it is dry, even if you don't take proper care of it. But sometimes some people will have actually a leaking belly button or umbilicus, or sometimes a pus will come, sometimes blood can come. So those are the children, especially when he's going into infancy after 1 year and all. So definitely this is the child who has some problem with the belly button. So belly button, actually all of us actually have got connections when the baby is within the mother's womb. So that is when uh, that is how actually we are fed. That's what actually is the standard teaching. So all of that connections will get disappeared automatically after the baby is born, and baby will start functioning by its own. But sometimes it happens that actually the baby's connections are retained. So it is because either it can be having a connection with the urinary bladder, or it can be having a connection with the intestine. If either of these two things are there, that is the time actually when a child needs a surgical attention, and we do the corrective surgery for that, and that will solve all the problems. And sometimes actually what we see is some holes in the body, especially they are seen in the face, because the development is such that actually the branchial sinuses actually will be forming, and then actually they'll be joining together, and they'll be leaving some gaps. So something like eyes, nose, and all. But by mistake, it can happen that the child is having some abnormal openings, something like preauricular sinus in front of the ear, or sometimes in the neck. We call it as a branchial sinus or pre-sternal sinus. So all these things, if it is left alone, nothing will happen. But one day it can happen that actually it will go into infection. Once it gets infected, then the chances of giving a good successful result is will become very low. So before it gets infected, it is a time when we should operate on these children, because it is something abnormal. We can't leave an abnormal thing on our child. So sometimes it happens that mother notices a lump anywhere, be it anywhere, actually, be it in the head and neck or be it anywhere else. So mother notices that, and then she is worried about it. And at the same time, actually, she will try to bring the child to a pediatric surgeon to find out what it is. Not every lump is simple. Not every lump is a cancer. This point all of us should understand. But every lump needs some or the other attention. And sometimes actually they'll go with medicines. They'll disappear without doing anything, but sometimes they require a surgical intervention or aggressive treatment modalities, especially if you are suspecting cancer also. Not that kids cannot have cancer, sometimes they do have cancers. So these are accidentally detected only. So I was talking about lymph nodes. Lymph nodes are some protective swellings all over the body. They are like, actually, I often tell they are like our dustbins in the body, in the room. So, like how actually at the end of the day, dustbin will be collecting some dust, and then the muck is going to go out of the room, and then it will be empty and fresh by the next day. Same way, lymph nodes function to remove all the dirt from that area. So these are protective lymph nodes. Sometimes the lymph nodes will get overburdened because of the infection, and very rarely they'll turn into pus, and that is when we call it as an abscess, which needs an incision and drainage, IND or removal of the pus, and very rarely actually they can turn into cancer also. So as a pediatric surgeon, we know actually this is a simple lymph node, this is a abscess lymph node, or this is a cancerous lymph node. So accordingly, we'll be advising some test called FNAC or biopsy, and then accordingly we'll be managing the patient. So I was talking about an abscess. Abscess is nothing but a collection of pus, means over growth of the microorganisms in a particular area because of whatever might be the infection. Will can turn into what is called as an abscess. When abscess forms, that needs pus is accumulating. So we don't try to want to keep any muck or dirt in the body. So abscess is also in a similar way, it needs to be removed. Sometimes actually parents pester us actually telling the doctor, please try to give this medicine, that medicine. If we don't give, actually they go to a different doctor there just to get a medicine, or they'll go to someone actually who will try to give some medicines actually to postpone the things. But in the bargain, the antibiotics use can turn a pus abscess into what is called as an antibioma. So sometimes it mimics a cancer, or it gives a disfigured swelling which cannot be managed properly in the later time. So that's why any abscess, if it is detected, it needs to be managed by timely surgery. So there is this, I kept this slide actually after the abscess because abscess and hemangioma both go hand in hand, both look red. It doesn't mean that every abscess is a hemangioma or say vice versa. So sometimes what happens is actually there will be a small red swelling. Sometimes if as a pediatric surgeon, we know it is a hemangioma. But if at all, if someone doesn't know that, and if he puts a knife on that, hemangiomas are nothing but it's a place actually abnormal growth, excess growth of blood vessels in one place. For example, all of us will have two or three veins here, blood vessels here. Sometimes some hundreds and thousands of blood vessels, if they stay together, it looks like a red hot swelling. So, but this should not be touched. Usually, what we are trying to do is like first giving some medicines, and after the medicines, if they're not working out, then we are trying to do an injection. If at all injection is not working out, then we'll be doing some corrective surgery to tackle this problem. This is what is about the hemangioma. So this is actually where actually one of our hemangioma patients is managed with medicines, and with medicines almost hardly any seen, visibly seen uh, marks are there, which they'll be able to manage in the future, like with little bit of makeup or something without an operation. So for everything, surgery is not the answer. So in the bumps and lumps, actually, I was talking about sometimes in the umbilicus or in the groin, actually, a mother might be noticing small swelling, especially when the baby is crying too much. So then she'll notice actually small lump will be there in the belly button, or above, or below, or in the groin, anywhere. Actually, some swelling which is coming out when the baby is crying and it is going back. That means it is a hernia. So hernia needs to be managed at some point of time. So our grandparents will be telling umbilical hernia, yes, it will resolve in 3 to 5 years. Yes, if it is umbilical hernia, it resolves in 3 to 5 years. But sometimes actually it is not only a simple umbilical hernia, it's something above or something below. Something above or below, it is not going to heal by itself. So, but sometimes it happens that actually in hernia intestine is coming out through a small ring and then it is not able to go back. So that is when actually it will go into what is called, we call it as a irreducibility. If it is becoming irreducible, then the chances of that bubble which has come, intestine which has come out, can go into strangulation. It is getting suffocated and it can get damaged and it can die as well. So before that happens, that is the time actually when you have to approach a pediatric surgeon to get a timely intervention management. So I was talking about something, some hernias above the umbilicus. So very much above the umbilicus, actually, in the what we call as epigastrium. In that area, if there is a small fatty nodule, that is what is called as a fatty hernia of linea alba. So that mimics more like a acidity. So, but it is not something to do with acidity problem, but it might be because actually there is a small bump or lump. If it is noticed, he needs a surgical attention. So coming to the hypothyroidism I was talking about in the previous slide, actually, so some child poor performance, very lethargic. Whatever you tell, actually he will tell no, or he will just sit in one place. He doesn't want to do anything. He doesn't have no interest in anything. And sometimes actually these people will be having an associated constipation as well. Hypothyroidism can lead to constipation, and sometimes they can have an umbilical hernia as well. So if one problem is there, as a good expectant, good mother or a good pediatric surgeon, we should see the other aspects also, and then we should manage the baby as a whole and give the proper treatment on time that saves the baby. Sometimes some children come with what we call it as a bleeding from the anus. So whenever the baby passes motion, he can pass blood in the motion. So that can be because of two reasons. One, the child is having a constipation, which is leading to very heavy hard stools, and then it is just tearing the anus and leads to some fissure. And because of the fissure, actually the blood can come. That is because of the hard constipation stools. And other common thing actually which we see is a solitary rectal polyp. So where a small, well, ball type swelling will be there, and which will have its own blood supply. When the heart stool presses over this ball or the rectal polyp, it will lead to bleeding. So by just actually as pediatric surgeon, we just put one finger inside the rectum just to see if it is, and usually it is a solitary one, and after removal of that, actually all these problems will be gone. So because we are talking about the bleeding from the anus. I'm talking about the intussusception also. Intussusception is a condition where one intestine is going into the other intestine, which we usually see within the first, second, or third year actually of the age. That is when actually these children can have blood coming out uh, from the rectum. So we call it as a red currant jelly. It's like a red currant, what which it's a jelly we eat. So it will be like looking like that. So if this is there, actually that is when actually mother should be smart enough to go to a pediatric surgeon and get the problem settled. And earlier we used to do more of operations, and nowadays we're doing more of ultrasound guided without any cut on the body. We're able to do it. If it fails, then we're going for what is called as a laparoscopy. So there is one more thing actually, hydrostatic reduction, where actually we try to manage without operation, and if that is successful, well. If it is not successful, then we'll go for laparoscopy and do the procedure. And in school going age, a continuation of the same spectrum, which is intussusception, but it is usually transient. A transient intussusception is a one where the small bowel overrides one more small bowel, and it will come back. It will come. It will. So in some scans it will be seen. In some scans it won't be seen. So this usually comes because the intestines are in a hurry to do something. So that is what, when the intestines are getting infected, it tries to go one over the other, and sometimes it will be swollen. So the swollen thing is taken and for granted by this fellow as maybe it is a motion, so fecal matter. That's why it will try to override this one. So this overriding is what is we call it as a interception. But it is usually small bowel to small bowel. The size is small, and usually they will be transient. Sometimes it will be seen, sometimes it won't be seen. So all the treatment that he requires is treatment of the underlying problem. Underlying problem is because of the infection. Infection is because actually he ate something nonsense outside and in an unhygienic way. Even we eat, but kids in that hurry they don't bother to wash their hands or take proper hygiene. Over that they have lower immunity. So the taking care of the kids is our as a mother or father. It is the parents' primary responsibility. So often, actually, kids are brought to us with a problem called my child is vomiting recurrently, frequently. And teachers also send the children out telling that, sorry, your child is vomiting. So please, parents, please come and take your child out. So that day, actually, we'll go out and we'll take the patient. That is mainly because the child had something undigested food by the previous day, or he is not able to digest that day. If it is sometime like something like that, it's okay. But sometimes it is happens regularly. So it can be because of, again, the child is poorly attentive in the class. Maybe he needs some behavioral therapy. That is one thing which we tend to ignore. But often, sometimes, as pediatrics, what we see is it can be because of the gastroesophageal reflux. The food is coming up frequently, and it is sometimes it is coming out as a vomiting. So if reflux is there, it needs an evaluation, and very rarely it can go for surgery as well. But sometimes it happens that intestines are rotated abnormally. So this abnormal rotation of the intestines also can lead to recurrent vomitings. So a recurrent vomiting cannot be taken lightly. It needs to be addressed properly, and pediatric surgeons know exactly what to do for this problem. So other complaint actually is your child is having recurrent problem. School teacher calls the parents and tells actually, okay, take the child home. So once in a while, it's okay, it's normal. So, but if it is happening regularly, then we should find out what is the reason. So sometimes it can be because of the appendicitis. Actually, the child is having recurrently. So appendicitis need to be tackled. And sometimes it is because actually you ate something outside. Actually, it is leading to infection. That is what leads to what is called as a mesenteric lymphadenitis. Actually, that needs to be addressed by proper hygienic way of eating, and sometimes we see metal diverticulitis. And the most important cause is the constipation. Constipation is the most neglected problem in the children. And with the trend of eating burgers, pizzas, or junk, and without actually proper fiber or water in the diet, definitely this constipation is increasing. That leads to having recurrent abdominal pains. So that's why most of our parents, we are taught actually to have a fast motion in the morning before going to the school. That is the best way of handling the baby, because properly eating food, properly good child who's eating proper food in proper time, definitely he'll be able to pass a normal school in the morning. So giving a proper breakfast and water in the morning, well before going to the school time, prevents a constipation. And sometimes it happens because it can be because of the urinary tract infections, or sometimes it will groin issues. Sometimes it will child actually is having a tummy ache. He may not be able to tell, but in his undergarments, maybe his testis has got some issue. He's not able to tell. He's not able to reveal in front of us. So little bit of examination by attentive mother is very important. So it can be because of torsion testis. So I was talking about the constipation as a recurrent cause for the recurrent abdominal pain. So if you don't, if as a pediatric surgeon, if we forget to take the history of bowel habits and constipation, then we are going to land in big mess. So we always make it a point that we'll be examining that, and then sometimes, actually, if necessary, we'll be putting our finger in the anus to just to check whether everything is perfect or not. Sometimes it happens that the child is having a small anus hole, which is leading to what we call it as an imperfect anus or covered anus. So these conditions actually will have actually anal stenosis. That is the reason for the problem. So if that is not tackled, so lifelong the child will be having constipation, pain of abdomen, and stool, indebtedness, all these problems, and he will be missing. Recently, we had a problem, a child of around 5 years old, and just in a casual examination, we found out that the child has got a anal stenosis. That is tackled, all the problems in the house with the child are gone. And sometimes, actually, in my areas of practice, sometimes some doctors, colleagues call me Dr. Enema. So, because what I was taught and what I used to practice is if a child is having a pain or pain, so if little bit of constipation history is there, we try to give the enema, and then with evacuation of the bowel, if the child is able to have a relief of pain abdomen, then it is because of the constipation. So it is very important to never to ignore a constipation history. So sometimes parents will be confused between constipation and diarrhea. Sometimes if the constipation is too much, if it is leading to hard stools, so around that actually form liquidy stools above the hard stools, they'll start coming out, and then they'll be staining our undergarments. And their parents will think that it is the child is not able to control his motion. It is not other way around. Actually, it is the hard stool which is not coming out, and which is giving a false impression that it is a diarrhea. This is what we call it as an encopresis. It's a very common problem, and his undergarments will be smelling badly, and it will be always wet. So these are the kind of conditions again to treat the constipation. So differentiating between constipation and encopresis is very important because if we don't understand, actually the child will be managed totally differently. So sometimes this constipation becomes a habit, especially in children. So sometimes actually, if the child is not adequately bowel or toilet trained, these are the children actually who will go into a habit of constipation. So these children, to prevent passing the motion feeling which is coming, so usually what they try to do is they try to keep both the legs together, and then they try to squeeze the buttocks, and then they try to stop the feeling of passing stools. So slowly over years they learn this, and then it will become a habit. Then the colon will become actually over distended, which is going to lead to so many problems along with urinary problems also. So the treatment of constipation is very simple, very easy, which we usually do it day in, day out, giving more fiber. Fiber is there only green leaves, vegetables, fruits. I always tell all the parents, don't give fruit juices and don't use grinder or mixie at home. So try to give actually mashed food rather than actually using actually like giving it like a juice. So fiber cannot be cut or split into powder. So try to give only fruits, vegetables, and green leaves as much as possible. Along with that, plenty of water. Kids need plenty of water. They'll be playing, they'll be dehydrated, and the stools can become hard. So if we don't tackle all these things, there can be blood in the stools, or it can that constipation can become a big habit. It's very difficult to come out of it. So it's a simple problem. If not ignored, it can be handled very well, and good parent can easily avoid all these problems. So we have what we call it as a Bristol stool chart. Actually, in that actually we ask the parents actually how is the type of the stool. So so always to have a happy family, actually the child should be passing a good stool. We often ignore it, but it is very important. So just to show example of actually how the anal orifice can be in abnormal place, which can lead to constipation. So if not seen properly, actually it can lead to problem. So this child has got a anal malformation problem where the anus is in abnormal place. It needs to be corrected. With simple correction, the life is set. And this is another example where we did anaplasty, the constipation is resolved, and all the problems are set. So the similar thing about constipation, ongoing constipation, it is not because of the diet itself alone. So then it can be because of absence of ganglion cells in one lowermost part of the colon, large intestine. So this we call it as a Hirschsprung's disease. Hirschsprung's disease, once it is, means usually these people will have very huge tummy, and the huge tummy will lead to give a suspicion to the pediatric surgeon. Maybe it is not a simple constipation child, it is a Hirschsprung's child. So then we'll be evaluating by doing a contrast enema, barium enema, or and then we'll be knowing that actually yes, it is a possible Hirschsprung's disease. And then because it is a later age child, so we tend to go in a two-stage operations, what we call it as a colostomy first, and then we'll do a pull-through operation after this colon shrinks in size at appropriate time in an appropriate way. That settles the problem for life. Coming to the pediatric urology, there are many problems actually which we say encounter in pediatric urology. And a little bit of genital problems awareness is very, very important in family. Actually, it is a parent's responsibility to tell about these genital issues. And if it is a boy, a father can take the lead. If it is a girl, a mother can take the lead. And nowadays, in most of the schools, actually, they are trying to show in the biology class or in the adolescent education programs, they are trying to give awareness about all the problems which they encounter in the boys and girls after they get some amount of maturity. Till that they reach that maturity, it is the parent's responsibility to take care of the boy or girl child and then teach him what is correct and what is wrong. So, for example, actually they can have a phimosis where the urine produces so tight it is not allowing the urine to come out, and that needs to be addressed differently. And sometimes actually the nowadays most of the kids have got pants with zippers. So sometimes if they don't wear underwear, actually the penile skin can go into the zipper. So the zipper entrapment is a common entity. So it's parents' responsibility to teach him to wear the undergarments. And sometimes the baby will be passing urine abnormally. Instead of being friend, actually he may be wetting his pants. Maybe some issue is there. Maybe so orifice hole of the tip of the hole is in an abnormal place. If it is an abnormal place, that's what we call it as a hypospadias. And sometimes the urination problems can be there. Sometimes it can be a smelly urine. All these things are telling that maybe child has got a urinary tract infection. And so sometimes actually there is a early puberty. So this needs to be addressed totally differently. And this is all about a genital awareness. So sometimes or quite often, actually parents will get annoyed in the night, telling that this child actually passes urine in the bed, actually won't allow me to sleep, actually is making a bed wet. And then that is not, unfortunately, it is not the child's mistake. It is something to do with our parenting as well, and sometimes child's problem also. So bedwetting is a common issue. It needs little bit of behavioral therapy and little bit of psychological therapy, and with that only, actually, most of the times it will be managed. And if it is not, actually, we have medicines for that. And so, good parenting by not giving actually too much of cell phone or video games or violent, scary shows in the night. All these things will come as bad dreams, and then the child may be being in the bed. So, it is our responsibility. So, bedtime stories of good people or sacred people is very important in a good parenting. So I was talking about genital awareness. In girls, sometimes what happens, actually, the both labia, actually, they'll be fused to each other. That's what we call it as a labial syndicate. It's a simple problem. But behind that, actually, urine is coming and going there, and it is infecting the whole area, and urine is stagnant. This will lead to recurrent urinary tract infections. A simple office procedure will be able to release this one, and then maybe a little bit of estrogen support is required for that patient for child some days, and with that, the problem is settled for life. So sometimes actually in boys, of course girls also, actually there will be some swellings in the groin. So it can be a hydrocele or it can be a hernia, or sometimes the scrotum in the child is empty. Means one testis is not missing, it is not there. Maybe it can be felt at a higher level, or sometimes it may not be felt at all. So that is what we call it as undescended testis. That needs to be addressed by 6 months of age. And after 6 months, actually, we start doing the operation, because after 6 months, there can be a significant damage which can start happening in the testis. So we should allow the first 6 months for it to naturally come down. If it is not naturally coming down, yes, we may have to go in and do the surgery and fix the testis in the right place. So again, I was talking about the hydrocele or hernia. Hydrocele is nothing but a fluid in the scrotum around the testis, which will actually the testis will look very big and the scrotum will look very big, and that is hydrocele. Usually we wait for 1 to 2 years maximum, and then after that I will be going for surgery. And the other thing is actually there can be a hernia as well. In hernia, what happens that intestines are coming out and going inside through a small drain called internal drain. So sometimes it can be on one side, sometimes it can be on both sides. When the parents come to us, they ask, "Doctor, is it there on the other side also?" So the answer for this is laparoscopy. By doing laparoscopy, we'll be able to see if it is on the both sides or if it is there only on one side. So I was talking about actually undergarments, problems in undergarments. Actually, as a rule, actually, as a pediatric surgeon or a good pediatrician, we are supposed to see all kids in total, not the areas which are exposed, which are shown. So we have to go in and we have to see, because at least one doctor should see once in lifetime. So sometimes what happens is actually a test ovary or testis. Actually, testis sometimes it will go into what is called a torsion. So if it goes into torsion, if it is not timely managed, then there is a possibility that we may have to knock out the testis. So the child will be left with only one testis, which needs to be properly fixed. So it can happen with anyone, any boy it can happen. And same way it can happen with the girls also. Sometimes that ovary actually will have some cysts. If the cysts are more than 5 or 6 centimeters, they'll just rotate over itself and lead to what is called as a torsion of the ovary. If it is not timely managed within the precious first few hours, the blood supply for that will go up, and we may be losing that ovary or the testis. So the protecting that ovary or testis in time is very important, and parents play a significant role in this detection. So this is what actually I was talking about, the oophoropexy, actually where the testis is fixed, it is called orchidopexy. If the ovary is fixed, it is called as a oophoropexy. This way, actually, we are protecting the ovary for life. So sometimes it is very difficult to differentiate between the simple infection of the testis or if it is a torsion of the testis. Usually, ultrasound will be able to tell whether it is a torsion or an infection, what we call it epidermolysis. So that needs medical management. This needs emergency operation. So the timely testing and timely operations are the key, and parents play a significant role. So don't be hesitant to lower the undergarments and see in your child. That's very important. So timely intervention of the testis is very important. Actually, nowadays we are trying not to remove the testis, even if it goes into torsion testis. We tend to protect it by doing some corrective operations. So again, I was talking about actually phimosis, where there is ballooning of prepuce. Where child is trying to pee, there is ballooning of the prepuce, and the skin is so tight, it is not allowing. So for that, we do a simple operation called circumcision, and sometimes it will lead to recurrent urinary tract infections also, and that needs to be tackled separately. So sometimes phimosis can be a reason for the urinary tract infection, and circumcision, if it is diagnosed to be the reason, and is definitely a useful tool. Sometimes parents notice that child's foreskin is little bit abnormal, thick, whitish, scarry. So that is the time when we call it as actually it's a type of skin lesion called lichen. So if that is there, it needs to be tackled differently, and it needs early surgery, early removal of that tight foreskin, and then the child needs ongoing dermatological management, and sometimes some steroids may have to be used, which a dermatologist will be telling you in detail. If it is not timely managed, it can lead to the damage can progress into the urethra and into urinary bladder also. So, wellness xerotica obliterans is a special entity which needs to be addressed, and parents will be able to diagnose, and then they'll be bringing it to us. So, what I was trying to tell is simple circumcision is not enough, especially when a urinary tract infection is diagnosed. And urinary tract infections are common. And if it is diagnosed, we have to see if this is because of actually sometimes the bladder, from bladder, it's supposed to come out. Sometimes it will be going up. If it is going up, then there is a possibility that it is a case of vesicoureteral reflux, what we call. So, in early grades, yes, actually, with medical management, it will be solved, and sometimes it can lead to end stage renal disease also. So we should not allow it to go into end stage renal disease. So vesicular reflux is a common problem where the urine will be going up instead of coming down. So whenever it is going up and coming down, going up and coming down, there is stagnation of the urine in the bladder and in the system. Anywhere stagnant water, it can lead to infection. So this infection, if it is going up and down, it will lead to infection of the whole kidney, ureter, bladder, full urinary system. So which can lead to damage to the kidneys in long run. So I was talking about actually there are various grades, up to 5 grades. So first few 3 grades usually we manage conservatively and with a little bit of infection, what we call it as uroprophylaxis. With that, actually the recurrent urinary tract infections can be prevented. So when urinary tract infections are prevented, the chances of kidney damage will be less. But in later grades, yes, we go for operation. And nowadays, what we are preferring is vesicoscopic urotracheal implantation, where we do like it's a minimal invasive surgery, something like more advanced than laparoscopy. So again, I was talking about constipation. But in this session, I want to highlight to all parents that constipation is a very important problem. If it is not diagnosed properly, there is a high chance that actually his bladder, intestines, urinary system, everything can go into a toss. So it can be really a cause for the urinary tract infections and kidney damage also. So timely management is very important. So I was talking about a wet umbilicus, wet belly button. So if a connection is there with the urinary tract, so then it will lead to what we call it as a patent urachus. If it is there, it needs to be addressed, it needs to be tackled, it needs to be removed. So with that, the permanent solution will be there. So umbilical issues are solved. So I was talking about hypospadias. When the child is not able to pee properly, a boy, and he is passing from under surface, and the urine will be spilling all over his pants and all. So this will lead to a social problem once he goes to school. So that's why before the child goes to school itself, we should try to correct this problem. So we'll be tackling this, and then with simple operations, timely operations. Sometimes actually it will be done tackled most often in the single stage or urethroplasty, and sometimes actually the child will require 2 stages because there will be associated bending of the penis, curvature of the penis also. So that needs to be tackled separately, and the whole, if it is in a very proximal place, means almost near the scrotum, sometimes we'll go for 2 stage operations as well. So, but it needs to be addressed before the child goes to the school. So, usually we start the operations from 1 year of age. There are various techniques for operations. Actually, as pediatric surgeons, we're well versed with all these techniques, and we'll give what best suits the child. And it's very important for as a man, or a boy, it's a pride to stand and pee properly in a less clumsy way. So if a hypospadias child, if it is not adequately treated or if it is improperly treated, at adolescence usually actually we'll ask the child, we call the parents of hypospadias and we'll tell them, is the child happy? Or we ask the child directly, are you happy with how the way you're being. Are there any problems? Are you facing any bullying issues? So then the child will be able to tell, yes, actually I have some concerns. So if these concerns are there, that child may ask for recall, and sometimes we'll be doing it. Recurrent reconstructive surgery to repair whatever residual problems are there, especially we do it at adolescent age, so that the child should be a completely good man, perfect man when he goes out. Sometimes parents will be coming to us and telling, my child has got only one kidney, one functioning kidney. That's what my doctor told. Is it okay? Yes, it's very much okay. So as we have seen actually the renal transplant programs where one donates to the other fellow, actually both live actually a happy, full lifetime normally. But only precaution we tell is you have a single kidney, take care of the kidney. Try to avoid injuries, too much of violent sports, accidents. They're preventable. By wearing a simple seatbelt, yes, you can prevent your accident. And and for these children, actually, some medicines are not to be given uh, frequently. Those we discuss in detail and short, and whenever they come and whenever they approach us. And it is our responsibility whenever a single child kidney comes. I will tell the parents these are the things that you are supposed to do and now what not. And coming to the kidney problems, there are several problems which are there in the kidney. All needs to be addressed differently, but most of the times actually they'll present with a urinary tract infection or an accidental ultrasound which was done for some other reason, and they'll find out that yes, this problem is there. That is when we come to know that actually this child has got some concern. A common problem is there is a block in the kidney outflow. That's what we call it as a pH obstruction and hydronephrosis because of pH obstruction. There's a block at that one simple area. That block needs to be tackled. Either we can do an open operation or sometimes actually we'll do what we call it as a laparoscopic pyeloplasty, which has become a gold standard nowadays. We will be removing that block and then we'll be fixing the block. So this is an example of our laparoscopic pyeloplasty which we have done. This is the latest trend. We are leaving 3 small holes on the baby without a big cut and beautifully healing scars, which may not be seen literally in the future life. So preventing a UTI, urinary tract infection, treating the urinary tract infection saves the kidneys. This is very important. So laparoscopy is a very important tool, and we are leaving the child with less pain, minimal scars, least hospital stay, and a deserving child definitely should be given the option of laparoscopy. It's just the latest trend. So earlier, what we used to do when maybe my previous generations, they used to do actually what we call laparoscopy means opening the abdomen, solving the problem, and coming out and giving the best care. Yes, but nowadays the trend is more towards laparoscopy. Laparoscopy, we are leaving minimal scars, and then with that, actually, we are achieving the same effective treatment solutions. So that is the beauty of laparoscopy. So as and when possible, actually, as pediatric surgeon, we are trying to give the laparoscopy as a primary option. So even complex operations, actually, we are able to leave minimal scars as a case of vulvar cyst, where if it had been done with open operation, I would have cut actually all across actually his stomach halfway through, and then did the same operation, which we are able to do by laparoscopy. So again, I talked about a hernia. Is it on one side or two sides? The answer is laparoscopy. So diaphragmatic hernia actually it's usually a pediatric, newborn pediatric problem, but sometimes it can come in later age of the life also. So the answer for this is thoracoscopy with 3 small holes in the thorax. That's what we call as thoracoscopy. So thoracoscopic procedures are giving really the wonder and the latest trend nowadays, and where for a simple pus collected in the chest, or it can be a lobe problems or some cysts. Just now we have done one thoracic duplication cyst in the 1 month old, like which is of around 2 centimeters. To do that operation, I have to open the full thorax, full chest. Instead of that, actually by doing 3 small holes, and you will be able to do the complete operation successfully with minimal morbidity and minimal problem for the family. So sometimes parents, mothers will be coming up with the problem. I'm giving a bath to my child. I found out that there is a small swelling in this area. Often, that it is how actually a Wilms tumor or kidney problems or kidney tumors, cancers, they come to us, and literally they'll have a normal life only all through. But suddenly, actually, mother noticed, and just casually she'll come to us. She'll get a letter, so and then in that we find out that actually there is a mass, there is a tumor. So it goes unnoticed. Actually, it's a parent's responsibility. Actually, so even actually a bath given by the mother is very important, and she's very delicate. She touches everywhere and she sees everything often. So a mother can never neglect a child. So mother, I always call her the first doctor and the doctor for the family. So, an alert mother and a smart pediatrician helps in early detection of the problem, and early solution for that problem is our responsibility. The kid needs this special eye. As pediatric surgeon, we are specialized, trained in giving that specialized care. In Kim's Cuddles, and our pediatric surgery team is very effectively working round the clock, 24 by 7, to give the best possible treatment for any child of with surgical problem, and we'll take care of the child. So, as a team, I told we have a teamwork, and our success rates are significantly very high, and we are giving the latest, recent advanced minimal invasive surgery and all the upgrade technologies, and we have robotic surgery as well in our King's College Hospital. So, giving quality, ethical healthcare to all our patients is our promise. So, we are available anytime and at Kim's Cuddles, Secunderabad, Kondapur, Gachbowli, and it's an exclusive unit for mother and children with all super specialists. And whatever is a process problem for the child, bring it to us. We are going to tackle this one, and we have a solution for everything. We'll take care of the child. Thank you very much. So we have some questions in the chat box, and for that, I, the child is diagnosed to have an undescended testis. What is the problem? So now we'll talk about. My child has got a kidney problem detected when I was in the womb. He's in the womb. How to proceed further? So often it happens that actually the fetal medicine has improved significantly, and in the womb itself, the parents are able to detect surgical problems. So then once the parents know that actually surgical problem is there, they come to us for counseling. We do the counseling, we tell what is the problem, we tell what is the solution for the problem. So sometimes in the newborn period, actually they get neglected and they go into the future, and after later ultrasound is done, and then they find out that actually the kidney problem is there. Kidney problems, most of them are correctable problems. So correctable problems have got every right to live, and it is our primary responsibility to give the best care. And without laparoscopic renal surgeries and all, we are able to give the best possible scar with that. And kidney problem needs, after evaluation, the proper treatment. So one common surgical problem in school-going children, which is often missed. So last school health camp, we diagnosed that preputial adhesions and phimosis are the common problems actually which are missed quite commonly. So the parents, they don't know how to push the scape or foreskin of the boy child back, and then in the bargain, actually he will be having what is called as a prepuce is adherent, and it will lead to recurrent infections, or it can be so tight and it needs a surgical correction by doing a circumcision operation. It's the commonest thing which we have noticed, and even hernia and hydrocele are commonly missed. And but unfortunately, because hydrocele is one problem which will be seen in the later part of the day. So mother gives a bath in the morning. Mother doesn't give usually a bath in the morning, evening. So that is how, as the evening progresses, actually, as the child is standing, then the water will start trickling into the scrotum. So then the hydrocele will start increasing. So hydrocele is usually a evening time problem which can be detected easily rather than seeing in the morning. So that is one other problem which can be missed very easily because of the daytime issues. So undescended testicle in a school aged boy. So sometimes actually parents come to us telling, sorry doctor, we missed in the newborn here. Now it is detected. So in the last school health camp we did, 8 children, actually we found out that children had undescended testis. Testis is not in the proper place. So if it is not in the proper place, if it will go into slowly some malfunction. And then sometimes it can go into what's called as torsion, epidermolysis, and sometimes they can land up in cancer if it is not detected and treated in time. So it needs to be managed ideally at any given point of time. Not that actually, if it is detected late, we have to remove the test. It's not like that. Yes, there is some amount of damage. It happened. It's okay, but at least we are able to protect the testis from that day itself. So doing the orchidopexy time in the time is the key. So the question is about hydrocele in school-going children. So earlier I told it is hydrocele is one thing which is commonly missed because hydrocele usually is more visible in the evening because the fluid will start coming out from that small tiny hole. It will be coming into the scrotal sac. It will be usually seen in the evening. And evening, actually, if the child complains, then only mother will be able to understand. Or sometimes when the mother changes the undergarments, then she should be a little bit more expectant. And then she should observe that yes, this child has got an issue. That is when they'll bring to the pediatric surgeon, and then they will diagnose that it is a case of a hydrocele. Sometimes it happens that actually it is not a simple hydrocele. If it is very heavy and if it is painless, it can be a tumor of the testis, cancer can happen in testis as well in children. So that is a possibility. The other possibility is actually when the child is crying, I told hernia can be there. Hernia is where intestines are coming. Instead of water coming down, intestines are coming down. If either of these two things are there, like scrotum is unequal. So one side is small, one side is big. So that is when actually parents will come to us to a pediatric surgeon telling that yes, my child has got an issue. So be it hydrocele or hernia, the treatment is surgery and it's a one-time solution. Usually we prefer to do it as a daycare operation or maximum 1 day stay. So that is a simple solution for a simple problem. So hernia is one or hydrocele, whatever it is, and is where intestines are coming down from the scrotum into the scrotum, and then they'll be going back. So usually they are noticed when the child is having some increased abdominal pressure. Abdominal pressure increases when the child is crying too much or there's a big blow on the abdomen. Sometimes while fighting and all, kids notice that there is a swelling in the groin. Usually they tell the mother, or sometimes it happens that actually even simple constipation when he's training too much, maybe it is coming out. So if it is coming out from the scrotum, a swelling is there, then he'll go into the mother, and then he'll be telling the mother, and then we'll diagnose that yes, it is a case of a hernia which is diagnosed. And then the simple answer is simple. We nowadays do a laparoscopic herniaotomy because by having laparoscopy, we can see both sides and tackle both sides at the same time. So it's very important to diagnose timely and give the correct treatment in the time. So I was talking about lymph nodes. There's a question in the chat. So how often do we get the mesenteric nodes? Mesenteric means intestinal nodes near the lymph nodes near the intestines. So mesenteric nodes increase, which all the body will have vessels, which are nodes, lymph nodes. So lymph nodes are there everywhere. They main work is scavenging, cleaning. So whenever we as human beings, I think we take really unhealthy in an unhealthy way. Usually kids they don't bother to wash their hands and then they eat and then that will lead to intestinal infection. Infection it will be carried to the nearest lymph nodes. So this is the scavenging organs. So they'll be taking the brunt on it and then they'll be increasing in size. So sometimes if it is increasing more, it will lead to pain. That's what we call it as a mesenteric lymphadenitis, which will lead to pain, abdomen. But the moment the infection comes down, slowly the lymph nodes also will start reducing in size. That is how the intestines will be infecting the lymph nodes, and lymph nodes will lead to mesenteric lymphadenitis, pain, and intestinal pain, and then slowly everything will start coming down the same way. So it is very important to notice this problem, and we always tell as doctors, pediatric doctors, we tell it's okay. Actually, they'll subside with the care which should be given to the intestines. So that solves the problem. So what is phimosis in school age boys? Yes, it's it's very frequently missed problem, and we see quite often. In last school health camp, I told there's a significant number of children who had phimosis. So not every phimosis requires operation, but most of them needs to be addressed and tackled in a different way. So usually we give an ointment and then we teach the parents how to take care of the foreskin. If it is working out, it's okay. If it is not working out, if it is leading to urinary tract infections, if it is leading to some major issues, that is when actually we plan for circumcision operation. Circumcision is not always mandatory, and over decades it has reduced. We have reduced our circumcision rate by almost 80 to 90%. So there's a question about what is the most common cause of hospitalization among children? So of course, medically, if you see simple infection, cough, cold, we manage conservatively at home or some pharmacist or something, and then we don't give the appropriate correct treatment for the baby. And that is how a lung infection, not a simple cough cold, will start upper respiratory tract infection, will start becoming a lower respiratory tract infection. So it should never happen. So unfortunately, those are the conditions actually where these children will go for lower GIT problems, and then they are the people who are getting admitted in the hospitals quite often. So COVID has taught us this actually timely treatment and timely proper food and time good healthy habits are very important in every family, and it's mother's role to take care of this. The other common problem actually what we see is pain abdomen, constipation, two things, and those are two are interrelated. Treat the constipation, give healthy food to the baby, and hardly any pain abdomen comes to children. Yes, there are some surgical problems like appendicitis and metal diverticulitis, all these things. Those needs surgical attention that will take care of. So whenever the parent child comes to me and asks, doctor, is it a very major operation? Should I be worried about this operation? So as a good doctor, I feel, as a good pediatric surgeon, I feel consoling a parent when he comes for surgery is my primary responsibility. I always, maybe I over exaggerate. I always tell parents, yes, it's a simple operation. We are well versed with it. We'll take care of it comfortably. Don't worry much. Because that reassurance only as a treating surgeon, I will be able to give it. So no, none of the textbooks, none of the internet, no Googling can give that answer. So I always tell them, it's a simple operation, I can do it. Yes, we'll be taking so much of tension in our hearts. But I personally feel the most toughest operations are something where life and death is at risk. Life and death risk is there. Something like a major cardiac issues, something like a major brain issues. Yes, everyone is really concerned. But in pediatric surgery per se, core pediatric surgery, most of the problems are very well managed, very conservative, comfortably managed, and we are very good at it, and we have adequate experience. So we give that reassurance to the family, and then we take the best care, and we give the parents the maximum reassurance and with best outcomes. It's our promise. At King's Cuddles, as a pediatric surgical team and the chief pediatric surgeon, and we do laparoscopy, pediatric urology, and we do robotic surgeries as well. And we are very good at it, and we give the best to your children. So be a good mother and good father, and treatment starts from your house. You're the doctor. So there's a question in the chat box telling humans can't digest fiber. Who said? So I'm telling you, the healthiest diet is fiber. Fiber is there only in three items. One is green leaves, one is vegetables, one is fruits. So fiber is not there in. I often tell most of the families and parents and kids especially to make them laugh and smile at me. I tell them fiber is not there in muscle fibers. Fiber is there only in green leaves, vegetables, fruits. Fiber is not only grass. Grass is eaten by animals, yes, but for us, the good fiber is green leaves, vegetables, fruits. Fibers is very important in our life. So newborns sometimes testis is not seen. So nowadays with the advent of preterm babies are coming very early. So preterm babies, there is around 40% instance that they will be having a undescended testis. Very low growth rate, very premature. So 40% instance means they came before. This descent of the testis, actually testis develops around the umbilicus area, and then it will start coming down, it will drop into the scrotum. This is how it comes. So in this process, the baby came out. So we have to give adequate time for the testis to drop down and come to the bottom of the scrotum. So usually it takes around 6 months. So beyond 6 months after age, usually we don't wait because then the electron microscopic changes will start setting in. That is why actually we try to operate after the testis doesn't come after 6 months of age also. So for first 6 months, don't panic. It will come down by itself naturally. Around 80% of the testes will come down to the base. So those 20% actually which are not coming down, those only will be touching and we'll be doing a corrective operation, what we call it as a orthodoxy. Sometimes we do open, sometimes we do laparoscopic orthodoxy. If it is in the abdomen, if it is not in outside, if it is inside the abdomen, we do it laparoscopically. So if any surgical problems are there, we are available round the clock as a team of pediatric surgeons and will be available 24 by 7 in Kim's Cuddles hospitals. And you can subscribe to our Kim's Cuddles website as well. And then we'll be tackling all your concerns with the utmost care and concern. This is our promise.